Welcome to Onc Now, the podcast where we explore the latest insights, breakthroughs, and challenges in the world of oncology. I'm your host for this episode, Dr. Jonathan Sackier, and today I'm honored to be joined by Professor Arndt Vogel. Professor Vogel is a professor and clinician scientist in the Division of Gastroenterology and Hepatology at the University of Toronto in Canada. He practices both at Toronto General Hospital and the Princess Margaret Cancer Centre, where his work bridges the lab and clinic in pursuit of more precise cancer therapies. So, welcome to the podcast, Professor Vogel. It's a real privilege to have you with us.
Yeah, thank you very much for inviting me. It's great to be here.
Fantastic. So, let's start with a couple of brief opening questions. You've dedicated much of your career to advancing the understanding of hepatobiliary and gastrointestinal cancers. What first inspired your focus on this area, and what continues to drive your passion today?
I think it's a mixture from my clinical interest, but also my basic research I'm conducting. And I think I started now more than 20 years ago when kind of was still in hepatology training, that I was more and more interested in liver cancer. At that time, we really did not have many options available. And while I was doing my postdoc, I really got an interest in preclinical research for liver cancer. And when I returned 2004 to Hanover, I decided that oncology, GI oncology, is really the field I would like to stay and continue and get more experience. And yeah, then this was basically the starting point. And I think much of my clinical interest was driven by my basic science interest. And so I really focused, as you said, the last 20 years very much on liver cancer, but still maintaining an interest in general GI oncology.
Yeah. So, liver cancer research has undergone a remarkable transformation in the last decade. And of course, our awareness of um, uh, predictive hepatic illnesses, MASH, and so on, and obviously hepatitis. So, if you look back at the early days of your career, what development still feels almost unbelievable to you today in terms of liver cancer?
I mean, first of all, what you are saying is that in liver cancer, we usually have two diseases, the underlying chronic liver disease and the cancer. And this is true specifically for hepatocellular carcinoma, where I think up to 70 to 80% of our patients have an underlying liver disease. So being more aware of liver cancer, um, increase our surveillance would definitely help to diagnose patients at an earlier step and would definitely improve outcome and survival rates compared to what we have today. But when I started 20 years ago, we had both for hepatocellular carcinoma and cholangiocarcinoma almost no treatments available. I mean, this was really in these early days terrible. No tyrosine kinase inhibitor. I mean, for HCC, we more or less had nothing. And for cholangiocarcinoma, we used gemcitabine. We had one not very effective systemic therapy available. And much was driven by local therapies and really testing and trying what we can do. And then at that time, I think um, it was not obvious how the field would move ahead. And I think in HCC, it is definitely the immunotherapy which really made a big impact and improved outcome and survival of our patients. And for cholangiocarcinomas, it's also a little bit immunotherapy, but more the targeted therapies that are available today. So for both tumor types, we really have made tremendous progress in the last 5, 6 years.
Sure. So let's come on to discuss ESMO a little bit. At the 2025 ESMO Congress, you led the ESMO clinical practice guidelines on hepatocellular carcinoma. Can you summarize what those updates mean for clinicians and patients alike?
Yeah, I think for hepatocellular carcinoma, as we have just discussed, the field is really moving forward. We have a lot of local therapies for which we usually do not have head-to-head comparisons. We have the systemic therapies which are moving to earlier stages, and we can combine local and systemic therapies, and we can apply local therapies after systemic therapies. So there's really a lot of things changing in the treatment algorithm. I think it's getting more and more complicated. And what we have emphasized not only in the guideline, but also in our meeting at ESMO is that the multidisciplinary tumor board is of utmost importance for patients with HTC, because here we can really discuss with all involved disciplines what would be the best next treatment option for a patient. And I think we should really not forget that this implies also potentially curative treatments such as resection, ablation, or transplant. And I think we really should not miss these opportunities for some of our patients that are really responding quite well to, for example, systemic therapies. So the MDT is most important today to really provide the best possible treatment for our patients.
We know that it's important to harmonize clinical practice guidelines internationally. It allows us to compare apples to apples in clinical trials and also to ensure that we improve outcomes in hepatocellular and other biliary cancers. Can you speak to that, please?
Yeah, I think that's definitely important. And there are two points I would like to make. One is that patients in Asia might be slightly different than patients in the West. So in Asia, we have more hepatitis B patients. Patients tend to be younger and have better preserved liver function, which can have a tremendous impact on which treatments we can apply, and also the approach to, for example, resection and surgery is different in the East and in the West, which makes it sometimes a little bit more difficult to agree on specific recommendations. And, for example, to define unresectable or borderline resectable, right? I think there are definitely differences between East and West. Nevertheless, having said that, ESMO was always very much involved in a pan-Asian adaptation of the ESMO guidelines, and we have done this also for the guidelines of hepatocellular carcinoma. And actually, just very recently, we have basically had a meeting with our Asian colleagues. Basically, all Asian societies were involved, and we discussed the most recent update of the ESMO clinical practice guideline. There was overall, I think, extreme high consensus on our recommendations. Some recommendations required discussions, but overall, I think most of our recommendations have been adopted by the Asian societies, which highlights that within ESMO, we are really trying to provide a global guideline that appears to be acceptable not only in the West, but also for our Asian colleagues.
Sure. So, for those who were not able to attend the meeting, can you take us to the most significant research that was presented in the field of hepatocellular carcinoma?
At ESMO, we had a couple of interesting studies. Nothing that is yet practice changing, but clearly highlights in which direction we are heading. So, starting with, and most of this is basically focused on intermediate stage HCC, which is probably the most complicated stage, because here we are really at the balance where we could either go to potential curative treatment or where we could end up in a palliative setting. And the question is, how should we best start, with local or systemic therapies? And there was one early trial from Germany, the ABC-HTC study, which basically compared TACE to atezobev systemic therapy. And this was an interim analysis, so still a lot of many open questions, but it indicated that the time to treatment failure may be even longer with systemic compared to local therapies. So it basically questions a little bit the old dogma, which is already not written in stone anymore, that intermediate stage is the domain of local therapy. So this is definitely changing. The other question is, what should we do with patients with vascular infiltration? And there was an interesting study from Asia highlighting that when we treat patients with atezo-bev, so systemic therapy first, then adding surgery in patients with vascular infiltration, which we would otherwise consider as contraindication, can have a better outcome. So progression-free survival and overall, and there was also a trend to better overall survival, again highlighting the need for tumor board discussions and to decide how can we best combine local and systemic therapies. And the last study, that was a phase 3 study, basically also from Asia, and as you can see, there are really a lot of data, a lot of trials from Asia coming up now, which basically looked at the perioperative treatment with camrelizumab and rivaroxaban in patients receiving surgery. And so far, we do not have any globally accepted or recommended neoadjuvant or adjuvant treatment. So at the moment, it's still surgery alone in clinical practice. And the CARES 009 study showed that with these Camrevo and immunotherapy-based combination therapies, we can basically improve event-free survival and recurrence-free survival, almost doubling the time from 20 or 40 months. Still, the event-free survival was very short. That were really high-risk patients, but again highlights that the future in HCC is certainly a combination of systemic and local therapies.
Okay, well, let's expand a little bit beyond ESMO in the field of hepatocellular carcinoma and other biliary tract cancers because of the evolution of immunotherapy and targeted agents. Can you tell us a little bit about which recent advances you find to be the most transformative for patient care?
So I think in the past, the first wave was certainly the tyrosine kinase inhibitors, which paved the way for systemic therapy in HCC, allowed for the first time sequential therapy. The second wave was certainly the IO-based combinations, which for the first time improved median overall survival to around 2 years, allowing complete responses with systemic therapy. So this were basically definitely something which had a tremendous impact on the outcome of our patient. So the question is, in which direction are we now heading? And I think one is ADCs. Most likely, and I see it more like a general concept in oncology at the moment, at least for solid tumors, that we do see these developments of ADCs, and many of these targets are also expressed in HCC. And we have in HCC some very interesting potential targets for ADCs, such as glupican 3. So I do think that with this, we may see kind of a revival of targeted chemotherapy in HCC, but maybe we do not couple these antibodies with chemotherapy as in other tumor types, but with, for example, radioligands. And there are some very interesting developments at the moment for radioligands coupled to antibodies, which will allow us basically a targeted radiotherapy, which implies that we can also use it for patients with, for example, extrahepatic disease. Having since we know that these tumors are really sensitive to radiotherapy, I think could be really interesting. And the last point would be CAR T cells. We have seen some very interesting data for CAR T cells. They clearly show us that we can achieve responses with CAR T cells in HCC. However, they are not yet very lasting. So there's still some work to do, some CAR T cell engineering, but if we are able to get more sustained responses, I think CAR T cells could also be very interesting in this disease.
Can we just go back to the targeted therapy? I've been reading quite a bit about targeted alpha therapy with actinium. And of course, there's the prior work with lutetium in urologic cancers. Which of the targeted therapies are you referring to for?
Yeah, this, for example, would be something we can apply. I think we do not yet have too many data for that, but any of these radioligands will be employed, and I think there's still an ongoing debate which one would be the best one. A couple of companies are exploring this at the moment, and I think we probably need to wait a little bit to see which one would be the most appropriate one. But the field is definitely moving in this direction.
Yeah, no. Certainly a very exciting space and showing great promise. So, biomarkers, that's a key element to precision oncology. What are the emerging biomarkers in hepatobiliary cancers and that hold promise for guiding therapy over the next few years? I mean, I'm thinking back to my days in medical school and when, you know, the first biomarkers were popping up alpha fetoprotein and such like. So, yeah, give us an update on biomarkers.
Yeah, that's a very good question. And I mean, think in HCC we are really lacking good biomarkers even today. And if you say that AFP was your biomarker, I think it's still the biomarker, right? It's a prognostic biomarker. It's not really helpful to guide treatment decisions. And I think here again there are really tremendous differences between cholangiocarcinoma and hepatocellular carcinoma. So in BTC, we do have all these genetic alterations for which we have molecular therapies available today in up to 40% of patients. And with the advent of KRAS G12D inhibitors, MTAP inhibitors, it can go up to 50, 60%. So in BTC, we have a lot of genetic alterations, which are definite good targets for molecular therapies. Yeah, and I think this field will evolve. At the moment, we are in the area of monotherapies. I think in the future, we will probably use more and more combination therapies to increase response rate, to have more durable responses. So genetic alterations are the key biomarker at the moment in cholangiocarcinomas. In HCC, it's really more difficult. We have a very clear understanding about the genetic alterations. Unfortunately, however, we do not yet have targeted therapies available. So beta-catenin is not really druggable, TERT mutations, p53. So all these really genetic alterations with a high prevalence are not really targets for systemic therapy at this point. We are moving in this direction. There are now the first drugs which may be specifically effective in patients with beta-catenin mutations. So eventually, I think we will get there, similar as KRAS was considered as non-druggable. Now we do see these KRAS, G12C, G12D, pan-RAS inhibitors. And I think probably also the targets we have in HCC will eventually become druggable, but this will definitely take some time. Otherwise, we have prognostic markers, of course, a couple of prognostic markers, starting from AFP or whatever function, ECOG, maybe some of the genetic alterations, but nothing that could really help us to guide treatment. And um, that's definitely something we are lacking. We have a lot of transcriptome data that have been looked at. Most of them have not been validated in independent cohorts, and none of them is really something we could use in clinic today.
Right, right. Watch this space. I'm sure with the passage of time, this field will grow as it has in other areas of medicine. So, from your perspective, what are some of the key unmet needs for patients living with these diseases, not only medically, but overall care, their care journey, and frankly, obviously, their quality of life?
I think for both hepatocellular carcinoma and cholangiocarcinomas, these patients require supportive care because, I mean, as I said in the beginning, most of them have two underlying diseases. Still, median overall survival is actually very short. It's around 1 year for BTC, around 2 years for HCC. And despite all the progress we have made, I think we definitely need to have supportive care programs. I see it now here in Canada. We have really a very good palliative care. We have dietitians. And I think this is something that is really extreme. I think extremely helpful and also extremely important for our patients. And so this best supportive care is something that um, we probably can still invest more. I do know that in many centers, countries. There are also specialized nurses to help patients, also to deal with side effects. But this is something that is not generally available, such as the drugs for which we know that they are effective. Yeah, there are still huge discrepancies between different countries and continents. To which extent drugs which we consider as effective and for which we have clear recommendations from national and international guidelines that are not really available to all patients. And I mean, here in Canada, the one if you don't have phase 3 data, no randomized trial, it's extremely difficult to get reimbursement for targeted therapies. And I think this is also definitely something we need to improve, that we come up with global recommendation. And I think if these recommendations are made by experts in the field globally, then also the agencies in the respective countries should follow them and allow reimbursement for these targeted therapies. I mean, we are talking about rare tumors in the West with smaller and smaller subgroups, and then it's sometimes really difficult to get the phase 3 data, which we could otherwise do in breast cancer or lung cancer, where we have hundred thousands of patients. That is simply not feasible with BTC and HCC. And I think we need to provide more equal access to drugs and treatments all over the world.
And what if we could screen at-risk patients, patients with fatty liver disease?
I mean, we can do that. We have clear recommendations for screening. I mean, we have recommendation for ultrasound plus AFP every 6 months for patients with, specifically if they have fibrosis, for patients with viral hepatitis. I think we have clear recommendations, but we have just recently published an update, and the usage of surveillance is only around 20%. Yeah. So despite the fact that there's a clear recommendation, but I think all guidelines, it's not been done. Yeah. And I mean, partly because some of our patients tend to not go to their physicians on a regular basis, which can certainly be a problem. But it's also not the only reason, right? There's still, I think, a definite underuse of surveillance in HCC, and I think we can all do better. Not only the patients, but also we as physicians can definitely do better and follow more of these recommendations for surveillance.
I think in the lung cancer world, there may be a parallel. You'll know, I'm sure, about the CT scan protocols that is picking up lung tumors much earlier in the process with a dramatic impact on survivability, disease-free, and overall survival, which is, of course, the most important thing. So, yeah, that's one to think about. On a lighter note, to finish off, if you had 3 magical wishes for the future of cancer research in your clinical area, what might they be?
The famous 3 wishes. Yeah, I think, I mean, one I mentioned already. So I think this is, since I'm in Canada, I'm more mindful about these access to drugs and therapies. I think this is something that is really important. I think we need to have um, more funding for liver cancer research. We need to develop better and more models to really advance the field in HCC. I mean, this is something with my basic research background, something I'm definitely interested in to move the field forward. And the third one, I don't know. I don't have a third one at the moment. Yeah. Um,
How's about more patients participating in screening programs
yeah,
so we pick
I
up
definitely. I take that. Yeah, 100%.
yeah, that would be a good one.
Yeah, I think that
Listen,
would really make a tremendous impact. I mean,
yeah.
100%.
And doesn't it, I think there are parallels in breast cancer that the people who don't get screened are the people who need to get screened.
Yes.
It's usually the case,
Yes.
isn't it? Yeah.
Yes.
Well, sadly, that's all we've got time for today. So I'd like to thank Professor Arndt Vogel for taking his time today to chat with us and all the work that you're doing for every patient and having lost friends to these wretched diseases. And as a surgeon who's looked after these diseases, thank you.
Thanks for inviting me. Always a pleasure.
Our pleasure. And to our audience, thanks for listening and for joining this episode of Onc Now. If you're not already a subscriber, subscribe. Spotify, Apple, you know where to go. Leave reviews, share episodes with your colleagues, and check out the archives. There's plenty of them. Until next time, everyone, please stay safe, stay well, and stay curious. Bye for now.